Good evening, everyone. Before I begin my welcome, I've been asked to just share some advice and instructions in the event that we have a fire alarm. So, upon activation of a fire alarm, immediate evacuation from the building through the nearest safe fire exit is required. There are marked fire exits on the front and the rear of this auditorium. So please take a moment to identify those. Here, behind you. The use of elevators would be prohibited during the alarm. Once outside the building, everyone must proceed to the assembly area and wait there until an all-clear signal is given by the fire department. The assembly area for this building is located on the University Green across the driveway from the front entrance of the building. All right, so with that behind us, good evening, everyone. It is my honor to welcome you to Seton Hall University's Affordable Care Act Symposium. I am certain that this is going to be a valuable learning experience for everyone here tonight because I know that I can't think of a topic that is timelier or more universally significant than healthcare reform. I just want to take a moment to thank those people who are responsible for making this event happen. First, I'd like to thank Net Impact, Seton Hall University's chapter of Net Impact, for sponsoring this symposium. I'd also like to thank my Stillman colleagues, Paul Alexander, Elvin Riley, for helping to bring this together. And of course, I am hugely indebted to the experts we have here from across our Seton Hall colleges and schools who will be sharing their unique perspectives on healthcare reform. And lastly, let me thank all of you for coming tonight. I hope you enjoy yourselves. I hope we all learn a lot. And I do hope that you'll ask some challenging questions of our panelists at the conclusion of the formal presentations. So let me now turn over the program to my colleague, Paula Alexander, who will be serving as convener and moderator of the panel. Thank you, everybody. Paula.
So good evening and welcome. We are very pleased to have a very distinguished panel of experts. These experts are our colleagues at Seton Hall University. So Phyllis Hansel is Dean of and Professor of the School of Nursing. She actually served on the committee of Congressman William Pascrell, who was one of the drafters of the Affordable Care Act. Ann Hewitt is the Program Director and Associate Professor for Masters of the Healthcare Administration at Seton Hall University, and she serves as the Director of the Center for Community and Population Health. Professor Andrew Huang is Associate Professor and Director for Global Health Studies at the School of Diplomacy and International Relations at Seton Hall University. He's a Senior Fellow for Global Health at the Council for Foreign Relations and the founding editor of Global Health Governance. Scott Rothbart is the Executive in Residence and Chief Market Strategist for the Stillman School of Business. He founded Lakeview Management Assets. He's a frequent contributor to Bloomberg News, CNN, and Fox. So welcome, and we're going to start with Professor Hewitt. Let me call up your presentation. So this is your presentation right here.
Oh, great.
And then this is here. Okay.
So what we have there. Okay, so let's go ahead.
Yeah,
It goes up to view.
Wait a minute, let's get rid of this. Let's escape from that. And let's just go over here and do this. Switch.
Okay.
okay, all right. Good evening, everyone. How are you tonight? It's a pleasure to be with you. I'd like to thank my distinguished colleagues for inviting me today. I think we have lots to talk about and not a lot of time. Being the first speaker on the program, you're usually asked to give an overview. In this case, it would be like doing the Bible in 7 slides or less. So I'm not going to go that way. I've got a couple slides, and then I'm going to show you a video. But I do want to give you a brief overview about the Affordable Care Act and frame the topic for you. Now, the diagram that you have, that you see on the screen before you, it's okay to laugh because I made it. And you can tell what I was trying to do was put the cross-out sign over what we call the medical care triangle. And our health triangle has three pieces to it: the cost of health care, access to health care, and quality of health care. So anything that we do in the health policy arena has to address cost, access, and quality. Now, the next point that I would like to make before I move on to the next slide is that I don't think there's anybody in here who would disagree with me when I say that our current healthcare system is in trouble. It's spiraling out of cost. It's fragmented. There are many pieces that work well, but there are just as many pieces who don't work well for many and some of our populations. And I'm just going to give you, run through this list very quickly of some of the reasons why I say our triangle is not working. First of all, 48 million of us in America do not have health care insurance. That's 48 million people. Second, our payment system is a nightmare. Right now, if you have diabetes and you need your foot amputated, it will be paid for. But if you need to have nutritional counseling and preventive care, it won't be paid for. Does that make sense to you? Probably not. The next point is quality care has an exorbitant cost that most of us do not recognize. A single minute in a hospital operating room, 1 minute in a hospital operating room, can cost anywhere from $800 to $1,200. That's from 1 minute. Next, hospitals in New Jersey receiving charity care, that's called uncompensated care, when people who can't afford health insurance come into the hospital. New Jersey hospitals can be paid as little as 5 cents on the dollar for every dollar of charity care that they provide. And finally, by the year 2021, 1/5 of our national economy will be spent on health care. So that's our fragmented healthcare system currently, and we've got to come up with a solution. The solution that's been proposed and was passed in March 2010 is called the Patient Protection and Affordable Care Act. And most of us think of it as the Affordable Care Act, or other people refer to it simply as Obamacare. I put this quote up because I think it puts into perspective, historically, as well as what we're talking about right now, how big and how huge this particular Healthcare Act is going to be for all of us. And as I'm looking out here at the audience, I'm thinking to myself, this is your future. This is the future of your health care that is taking place right now and that we're defining and is being refined. But the idea that this is the biggest game changer in healthcare since 1965, we're going back more than 50 years to come across any piece of health policy legislation that has an impact, such as this. Now, rather than explain all the pieces to you and take 20 minutes, what we have is a video, and let me just click right here, and we should have it play. Okay. This one, let's see if we can do it. No, I went back. Let me minimize this. Keeps going on. And there we go.
Well, it's finally happening. After years of drama on Capitol Hill, a Supreme Court case, a presidential election, And a Mayan apocalypse that could have stopped it dead in its tracks but didn't? The marquee elements of the Affordable Care Act, sometimes called Obamacare, are about to kick in, and big changes are coming to health insurance in 2014. In the next few minutes, you'll get a pretty good lay of the land by once again watching your fellow Americans, the U-Tunes, find their way through the system. There are 4 main ways nearly all of us will experience health care once the health reform law goes fully into effect. About half of us will get insurance through our jobs, just like today. About a third will get covered by the government through Medicare and Medicaid. About 1 in 10 will buy insurance themselves. And unfortunately, another 30 million of us or so, just under 1 in 10, still may not have coverage at all. But let's begin in the workplace. Many Americans are already covered by their employers, and for them, not a whole lot will change. There will be some new advantages, though, like caps on how much you have to pay out of pocket, and free preventative care. The bigger changes are coming for those who work for larger companies but aren't covered now. That's because the government is going to require companies with 50 or more employees to cover full-time workers or pay a penalty. So, more workers may find themselves covered. Smaller employers won't face the same penalties for refusing to buy insurance, but they'll be encouraged to do so. The government will be setting up special marketplaces to make it easier for small employers to take the plunge. Some will be offered temporary tax breaks if they do, and unlike now, insurers can't inflate prices if some employees are sick. So many of us will be getting covered at work. A lot of us will be covered with help from the government, just like today. Not much will change for seniors on Medicare. The law has already started helping with prescription drugs and better preventative care, and that will continue. Medicaid, on the other hand, is expanding to cover more of us, especially poor adults, many of whom aren't eligible today. If your income is low, Medicaid will cover you, most likely in a private insurance plan. But there's a catch. The Supreme Court ruled that governors and legislatures of each state should decide whether or not to be part of expanding Medicaid. In states that get on board, the feds will cover almost all the cost. But for those who don't, you may be left with the same options you have today if you're poor. So you'll want to check out your state's decision if you think you might qualify for Medicaid. Even with employer coverage and the expansion of Medicaid, a lot of us will still be left out. For those not covered or who find their work coverage too expensive, a new way to buy insurance on our own will be popping up everywhere. They're called health insurance marketplaces, though they may have a fancier name than that in your state. The health insurance marketplace is like a virtual insurance mega mall. Here you'll find private insurers competing for your business, and you'll be able to pick out how much coverage you want and how much you want to pay for it. From cheaper, high-deductible bronze plans to more expensive platinum plans. Still, all plans will cover a comprehensive set of services like hospital and doctor visits, maternity care, mental health care, and drugs. Most everything any of us need, at least when it comes to medical care. As with Medicaid, not all governors are on board to set up these marketplaces, but the feds will open their own in those states, and so you probably won't notice much of a difference. One big advantage of buying insurance through these new marketplaces is that the federal government will provide most people with a tax credit to make insurance more affordable if you don't have any other options and your income is below a certain level. In fact, most people buying on their own will be eligible for a tax credit and won't have to pay the whole premium themselves. And the marketplaces will make sure that insurance companies operate fairly under strict rules. They'll have to offer everyone insurance, even if they're sick. And they won't be able to charge more for pre-existing conditions. Unlike today, men and women will pay the same price. And prices for older people will come down, while young people will pay more. To keep costs down for young people, though, they'll be able to stay on their parents' plans until 26 and buy low-budget catastrophic plans until they're 30. Of course, all these changes still don't mean insurance will come cheap. Most people buying their own coverage will end up paying less with the new health insurance tax credits. But some people will have to pay more, even though many of them will be getting better and more secure insurance. So let's be realistic. Not everyone's going to run out and buy insurance. Some might say, hold on a minute. If I can't be turned down or charged more, why not just wait until I get sick or injured to buy insurance at all? Well, first, you can only get coverage during special enrollment periods, so if you snooze, you may lose. And second, thanks to something called the individual mandate, if you're not insured, you pay a fine, making this option seem not nearly so clever. Still, if you really can't afford to buy in and can't get insurance anywhere else, the government will waive the penalty, so don't panic. By now, you've probably noticed a lot more people will be getting a lot more coverage. Where will the money to pay for that come from? Taxes, many of them targeted at the health industry itself, even tanning services. Yes, individuals will pay too, mostly the wealthiest Americans, who will be paying more into Medicare. Also, hospitals and insurance companies participating in Medicare will get paid somewhat less. Not painless, but somebody's got to pay. So, as Americans prepare for 2014, how will you be covered? How would you like to be? Now's the time to figure it out and get on the path to setting yourself up for the best insurance at the best price. After all, who wouldn't want that?
All right, we're back to my slides now. That was from the Kaiser Family Foundation, and I will share with you, especially students, that they have a website that has frequently asked questions on it, so that if you need to do any kind of deeper digging into these concepts, there's the place to go. They've got it outlined for you. Very quickly, because I know our other my other colleagues would like to speak to you on some of these topics. I went through, and the reason that the letters are so different is to represent that these are unintended consequences or surprises of the Affordable Care Act that have occurred in the last 3 years, almost 4 years now at this point. First of all, I'm sure no one, even if they thought it was going to be an unusually difficult rollout, expected that it was going to be such a disaster as it is. So we've got a rollout disaster that we're dealing with. Second of all, navigators, if you haven't heard that term before, these were the people that were trained to help those who didn't have knowledge about healthcare insurance, how to select among all the different plans that were offered in the healthcare insurance exchanges. The third big surprise for the feds, I believe, is the fact that 36 states said, you know what, we're not going to set up our own, we're going to let you do it. So the burden went back to the federal government, and I don't feel that they were prepared that many states were going to relinquish to them. Letter D, the welcome mat effect is the opposite of what we call the woodwork effect, and that's the idea that Medicaid has been available for a lot of these uninsured people, and they never took the opportunity to enroll in it. So a lot of the folks that are enrolling right now could have been covered by Medicaid before. So whether they're coming out of the woodwork or they feel there's a welcome mat and now they're welcome to purchase the insurance, they're not really sure. But I love both those words, the woodwork and the welcome mat. Letter E is the canceled health plans, and that has been the health story for the last 2 weeks, that people who bought healthcare insurance as individuals are getting their health plans canceled before January 1, 2014. And a lot of that has to do with those current health plans didn't cover the essential health benefits that are part of the Affordable Care Act. And last but not least is the FSA rollovers. That's where you can take $500 or a certain amount pre-tax, use it for health care. That has been extended. You don't have to spend all of that health care money in 1 year. You can roll it over to the next year. So those are the surprises to date. Some of the terms that you've already heard, I'm not going to go through them. I just want to highlight one. Young Invincible. Those of you in the room are called Young Invincibles. You are the folks who don't believe that you're going to be ill, so why should you go out and buy the individual participate in the individual mandate, and you're the ones who have the potential to upset the whole health risk pool if not enough young people participate. And last but not least, I think, is we need to look at what has been positive so far in the 3 years that we've had the Affordable Care Act and what hasn't been. On the pro side, you saw before, children under 26 can be covered under their parents. Women's preventive services have been added and are being implemented into our coverage. No pre-existing condition refusals by health insurance companies. ACOs stand for Accountable Care Organizations, and those are organizations that are targeting Medicare patients, and if they produce quality, they are rewarded with incentives. PCMH stands for Patient-Centered Medical Home, and it's an idea of, instead of the patient running around to all the different providers, let's bring all the providers to the patient. So those are the pros. On the other side, you can kind of put these in one basket and say, we're looking at some real issues when it comes to business, insurance, risk policies. The other exception to that line would be the availability of healthcare providers. How much is the Affordable Care Act going to pay for them? So that is my presentation, and I'm going to turn it back over to our moderator now.
So Dean Hansel will be speaking next, and she'll be speaking, I think, about the intended and unintended consequences of the Affordable Care Act. And this is your presentation.
Good evening. It's my pleasure to be here to speak about this very important piece of legislation. I had the honor and privilege of working with Congressman Pascarell. Doesn't mean that I agree with everything in the bill, but if you remember when the bill passed, what Nancy Pelosi said, we'll have to read the bill to find out what is in it, all 1,000 pages of it. Now, probably this will be a surprise to most of you. All of the Title VIII funding that supports nursing education was included in this bill. The total dollar figure is not stunning at all in terms of federal health dollars. $243 million is not much at all. I conclude that when I look at the National Institutes of Health, that within it includes the National Institute for Nursing Research, which receives $160 million a year in funding. That represents less than 1% of the total NIH budget. So nursing and the practice of nursing is not getting their fair share there at all. One of the reasons why the Title VIII funding is part of this bill is because nursing is the largest of all health professions. Nursing comprises 3.3 million practicing nurses in the United States. A quick comparison to compare that to the number of physicians, number about 600,000. So nurses really move the system. Some of these items in here are very important to us here at Seton Hall and the College of Nursing, such as the Nursing Student Loan Program, the education training related to geriatrics, the advanced nursing education, education and retention grants, the Nurse Loan Faculty Repayment and Scholarship Fund. We have one of those grants, along with the Nurse Faculty Loan Program, workforce diversity, health professions and information, health centers that are nurse managed, commissioned corps, expanding the access to primary health care services and general surgery services, maternal, infant, and early child home visiting programs, home medical practice demonstration programs, community-based transmission programs, patient-centered outcomes research, non-discriminations in healthcare, improved access for certified nurse midwives, and even more. The list goes on in terms of what is included in this bill. All of this is targeted at improving healthcare outcomes for all. I mean, in looking at the bill, I finally come to the point where I call it the good, the bad, and the ugly. Some of the good things were the expansion of Medicaid. But as Dr. Hewitt said, there have always been many individuals eligible for Medicaid who don't sign up. These are state programs, and in the state of New Jersey, we not only have Medicaid, but we have special provisions for providing health care coverage for children who are not covered by their parents. Dependent children through the age of 26 are covered now, which meant a lot to me. I just found out recently that if I were to have put my son on Cobra here at Seton Hall at age 23, it would have been about $850 a month. So over the course of 3 years, the insurance coverage used to end at age 23, and now it goes up to age 26. That represents about $30,000 to me for one child. I mean, if you have 2 and 3, that is a lot of money. So that is a very good thing. Also, no denial for pre-existing conditions. In the past, if you had a pre-existing condition and you had a gap in your coverage, you would be hard-pressed to find another policy. Hopefully, we're going to see the expansion of the insured population. And, I mean, in New Jersey, I think it's going to be very interesting to see how this takes form and what it all means. Hospitals in this state are in a very vulnerable situation. I think there's only about one hospital in this state that has a margin that is greater than 5%. They all operate on the edge. And as soon as a hospital is in a situation where they are dependent upon government-funded providers, such as Medicare and Medicaid, the reimbursement is insufficient for the hospital to stay afloat. So that's why over the past 20 years, we've seen probably about 25 hospitals, or close to 25 hospitals, close in this state. New Jersey is unique. I've compared it to Massachusetts and Connecticut in terms of healthcare dollars that are awarded by the federal government. Interestingly, New Jersey gets less than both of those states in terms of federally qualified health centers, yet we are probably the smallest state with the largest number of old industrial cities. And in the old industrial cities, there's a lot of poverty. Coverage for part-time employees that meet certain criteria. I believe if you work 26 hours a week now, the employer has to cover you. And I mean, this is something for Seton Hall to pay attention to, because I think we may have some adjunct professors that are in that situation that don't quite get coverage now. Emerging problems. This is part of the bad. The functionality of the website. You know, we should have recommended Steve Landry and Paul Fisher to them to get it right. The elimination of individual plans that don't meet the criteria. Many policies have been canceled, and this is especially problematic for individuals with a chronic illness that need their health insurance to make it from 1 week to the next. I don't know what's going to happen to those individuals. I mean, the president has said that we're going to defer that until next year, but I don't know that the insurance companies are going to be required necessarily to provide the insurance coverage that they had been providing. The networks through the plans that are available through the government site have been described to have limited, narrow networks. of providers, which may be fine for an individual who is healthy, but you never know what the future is going to bring. And if you develop an unusual disease that is not cared for within the network, if you need to go to a major center, if you develop a debilitating neurological disease, that's going to be quite challenging. We had the promise that from the president that you could keep your own, but we're finding out that that's not happening. I had lunch with a gentleman a couple of weeks ago who's one of our generous donors at Seton Hall, and he's 85, and he's on Medicare, but he has a supplement. He has a lot of health problems. And he was telling me he wanted to change to the AARP plan because it was cheaper, but he found out that that plan didn't cover his physician. So he wanted to stay with his own physician, so then he had to go for a more expensive plan. Cost, I think, is escalating significantly for many who didn't anticipate it. And I fear that small businesses will be cutting their workforce. The dynamics of health facility finance. We have the compensation of providers that work for healthcare facilities. And as I said earlier, very slim margin in hospitals. Community Hospital in Toms River just eliminated 100 positions, as did Newark Beth Israel. I mean, I think the hospitals are running scared here. With the new provisions in Medicare, patients that are readmitted to the hospital within 30 days or who have an incident in the hospital, those costs must be absorbed by the hospital. So what is the hospital going to do if it has less revenue? It's going to cut its workforce. I think we're going to see the cost of policies increasing, loss of employment, and I think everyone knows or should know that Medicare and Medicaid under-reimburse. And potentially there's going to be more out-of-pocket for serious chronic illness. Advantages and disadvantages. Obamacare, and I'm not the economics professor, we have one of those here to follow me, but it is interfering with free market dynamics, and it's probably going to have some adverse effect on the quality of health care we receive. Government control usually does not drive up quality. We'll have many, many difficult decisions for all of us. The effect on patient care outcomes is yet to be determined, and reimbursement for repeated admissions will be at the hospital's expense. I thank you.
All right, so Professor Rothberg will be next, and I think he will continue some of the difficult stories. And remember, the panelists will dialogue among each other, and then we'll have questions from the floor after that. This is the cover of the New Yorker.
Thank you, Dean Strauss and Professor Alexander. I believe this is the 5th year that we've now done this, and I've been fortunate enough to participate in all of them. And hopefully we can continue with crises so that I can speak again in the future. What I'd like to do is I'm going to start off by giving you some presidential quotes. Then I'm going to level set some facts. We'll talk about some of the economic and financial aspects and consequences of the law, and then I'll end off with some other presidential quotes from a different president. Let me start off. As Ronald Reagan was being taken into the operating room after his 1981 assassination attempt, he said to all the doctors and nurses assembled, "I hope you're Republicans." He also said government is like a baby, an alimentary canal with one big appetite at one end and no sense of responsibility at the other. And finally, he said, the 9 most terrifying words in the English language are, "I'm from the government and I'm here to help." So with that in mind, let me level set a few things, because I think unfortunately what happens is that the media tends to distort some of the impressions that we get from some of the political actors that are involved in healthcare and other matters in what I call dysfunction junction, or Washington, D.C. Let me start off by saying not all Republicans are white, hooded, cross-burning racists, despite perhaps what you may hear from Oliver Stone. Second of all, not all Democrats are atheists devoid of faith. Right? Healthcare is a concern for all Americans. Right? It's not a concern for the left. It's not a concern for the right. It's not a concern for the poor. It's not a concern for the rich. It's a concern for all. Right? The Supreme Court ruled, and this is very important, that the ACA mandate is constitutional as it is viewed as a tax. However, the Supreme Court did not rule on the efficacy of the ACA. So the Supreme Court didn't say this is a good law, or this is a bad law, or this law will work, or it won't work. They merely said that as a tax, the mandate is constitutionally legal. So what happened? Well, I think we have to say that Obamacare gets an A for altruism. It really tried hard, okay? However, when it comes to design, and certainly when it comes to execution, I believe it gets a big fat F. Let's understand a little bit more. First of all, what is the ACA, or Obamacare? Right? Is it a health care law, or is it a health insurance law? See, and I think that's what most people don't quite understand. What this country needed was a health care law that encompassed health insurance. Instead, we got a health care law, a health care insurance law, which had, to some extent, some aspects of health care law involved. All right? For instance, did it really go far enough to explore what happens on the cost side? Now, we just heard from the dean that, yes, it does to some extent, but it really wasn't across the board looking at the cost of health care. All right? Another thing that it didn't look at, and one of the largest costs involved in health care, right, which is perhaps a hidden cost, but certainly embedded there, is the cost of torts. Right? How much money either doctors, nurses, healthcare facilities have to pay, either in terms of insurance or in terms of the legal claims that are assessed against them in a court of law. Right? And unfortunately, the ACA did not do anything in terms of controlling what I think are the most rapidly growing parts of the cost of our healthcare system. Let me talk a little bit about insurance, because it seems to be more of an insurance law than anything else. Okay? In the finance world, we teach not about insurance, but we teach about risk and insurance. They go hand in hand. Right? And insurance is priced based upon risk. Right? For example, a healthy 50-year-old male will have a lower life insurance premium than that of a 50-year-old male who smokes, drinks, and has diabetes. Right? The insurance company is accepting more risk from the second type of individual than the first, hence they need to price insurance higher for them. Well, is that what is happening under the Obamacare law? Well, not really. Because as we saw before in the cartoon, and by the way, there are 2 rules that I've learned: never go on stage with children or with animals, and now there's a third one: never go on stage with a cartoon. How can I beat that cartoon? all right? But Obamacare has an egalitarian cost structure, as you saw before in the cartoon, all right, which only varies based upon the level of service that you elect, right? In the past, older individuals who tend to have more health risk paid as much as 6 to 1, more in terms of healthcare costs, than younger, healthier people. Now that ratio is going down to about 2 to 3 to 1. Right? As a result of that, what we've had is a distortion, a bastardization of the whole concept of risk and insurance. And so we've created a healthcare insurance system which does not disincentivize poor health behavior, but rather it creates a systemic moral hazard within the healthcare system. Right? In other words, you are not being penalized, right, for eating fatty foods, smoking, drinking, or doing other things that might create a higher health risk for you. Right? Let's exclude, of course, anything that may be genetic, of course. Right? So for those of you who don't understand what moral hazard is a situation in which you do not penalize bad behavior. Now let's talk a little bit about economics. All right? Now let me throw up something here. Okay. What I have up here, all right, is your traditional supply-demand chart, okay? And normally, and I'll use the arrow here, all right, under normal conditions, there's our supply. There's the equilibrium point of our supply and demand, right? And you will see where the cost would be, and this is the quantity along here, right? Now, what we've done is we've created a health insurance plan whereby the government provides subsidies. So, according to economic theory, what happens is subsidies shift the demand curve up, right? You are able to create more demand by subsidizing, right? What happens is you do get more people involved in the transaction, but costs do go up, right? And so that's what's going to happen according to pure economics when it comes to the subsidy aspect, right? But there's another side to everything, right? Who's going to pay for everything? Well, we have something called the employer mandate, all right? And I think that this is something that is not very well understood. We touched on it before. Let me expand on it a little bit. All right? The annual employer mandate fee, okay, is a per employee fee for employees with over 50 full-time equivalent employees who don't offer health coverage to full-time employees. It's a penalty, right? But it's been considered a tax, right? It's based upon full-time equivalent employees, not full-time employees. There's actually a formula whereby you convert non-full-time employees to full-time equivalents, okay? The fee is based on whether or not you offer affordable health insurance to your employees that provides minimum value, which is explained within the law. The annual fee is $2,000 per employee if insurance isn't offered. Right? The first 30 full-time employees are exempt. Now, another way to pay for all this is that we have slapped on a 3.8% Medicare tax or surcharge on unearned net investment income. Right? This kicks in for anybody who has an adjusted gross income in excess of $200,000 per year or $250,000 for married couples. Right? What this does is it basically creates a tax for the people who are the creators of capital in the system. Right? So potentially what's going to happen is you're going to shift money that is being used to hire people to start new businesses, to pay for taxes. What you're also going to do is you're going to create a system whereby now the demand for interest rates on investments is going to be escalated because of the after-tax impact. Right? That eventually does create inflation in the system. What are some of the unintended consequences on jobs as a result of all this? Well, first thing is employers already caught on to this, by the way, before 2013, 2014. They got ready. They started cutting down their workforces to below 50 full-time equivalents. Right? Right? Companies are converting staff from employee status to independent contractor status. And as an independent contractor, you do not have to provide insurance for someone. I've known people who've gone through this. They got called into their company and they said, you are now all independent contractors as of a certain date. Guess what? We're going to pay you with what's called a 1099 rather than the W-2. Good luck to you. Buy your insurance on your own. Right? Some of them were kind enough to say, we will make an adjustment, so we'll pay you a little bit more to compensate you for the difference. At least that was the additional compensation in 2012 to 2013 terms, not necessarily in 2014, 2015 terms, depending upon what your cost may be if you can get insurance. Right? The use of temporary staff rather than employee staffing, i.e., call up a temporary agency, right? Hire a secretary, hire an office staff, a mailroom clerk on a temporary basis. You may pay a little bit more for that temporary staff, but you don't have to give them benefits. We're seeing closing of businesses who can't afford either the insurance or the tax. Face it, if you have, let's say, 60 employees, and you may have to pay a $2,000 penalty or buy the insurance, right? You may have a Hobson's choice. Either way in which you decide to go is going to be too costly. Right? There are instances of companies that have closed down in anticipation of this. We're going to have increased health care services at a higher cost to consumers. Something has to compensate for all these additional costs, certainly. Okay? And I mentioned before the higher interest demanded on earning income. I'm not going to play this today, but write this down. There was a doctor by the name of Lee Heeb, H-I-E-B. I don't know if any of you have seen her speech that she gave, but she talked about government overregulation hurting patients. There's a very interesting YouTube video that I think you'd like to see. So I want to conclude here with another presidential quote. All right? And I think we know who said this. And it was a gentleman who was laid to rest 50 years ago. And he said, I believe that this nation should commit itself to achieving the goal, before this decade is out, of landing a man on the moon and returning him safely to Earth. This decision demands a major national commitment of scientific and technical manpower, material and facilities, and the possibility of their diversion from other important activities where they are already thinly spread. It means a degree of dedication, organization, and discipline which have not always characterized our research and development efforts. It means we cannot afford undue work stoppages, inflated cost of material talent, wasteful interagency rivalries, or a high turnover of key personnel. New objectives and new money cannot solve these problems. They could, in fact, aggravate them further unless every scientist, every engineer, every serviceman, every technician, contractor, and civil servant gives his personal pledge that this nation will move forward with the full speed of freedom in the exciting adventure of space. A few months later, he went on to say, we choose to go to the moon in this decade and do other things, not because they are easy, but because they are hard. And JFK said this. Now imagine if we took his words and instead of talking about how we can do all this for space exploration, we could do it for healthcare. Thank you very much.
will be speaking to us and putting this in a global context. Some of the problems that we're facing in the U.S. Will be put into a global context.
Thank you, Paula. Can you hear me? Okay. Well, as Paula's introduction indicated, I'm not expert on Obamacare. It happened that I was one of the authors of the Council on Foreign Relations report on universal health coverage. So when I think that was last June, after the Supreme Court ruling upholding the Obama's healthcare law, I received a phone call from ABC News asking me to comment on the fact that some people were so disillusioned with the United States, that they posted, on the Facebook and Twitter that they were jumping ship and moving to Canada to avoid Obamacare. I said, but the problem is that in Canada, right, actually the healthcare system was probably more government regulated, so that would only look Obamacare looked like the poster child for free market capitalism. So some people may think of moving south to Mexico. That didn't work either, because almost the entire Mexican population gets their health care from a Medicaid-like system funded by the government. What about Europe? Right? That is not going to work either, because actually the 25 wealthiest nations in the world now all have some form of universal coverage. Right? And that makes us the only exception. So I was then asked about the reporters, where can people disillusioned by Obamacare turn to find a country whose healthcare system has less governmental involvement than the United States? Then I said it would be most likely a third world country, or maybe sub-Saharan Africa. Well, this episode I think is illustrative in that by implementing Obamacare, I think the United States finally joined the global movement building universal health coverage, that required everybody to receive affordable, quality health care. And in fact, I would call this a new movement, the third wave of universal coverage, if we count the establishment of the welfare state in the post-war era as the first wave. The second wave began when Brazil made this landmark decision to establish a unified health system in 1988. The current wave, the third wave, began essentially 4 or 5 years ago, 2008. The World Bank began to support health systems, strengthening efforts in countries like India, several African nations, and throughout the Southeast Asia. And then in 2009, China kicked off its new healthcare reform, and that promised to provide basic healthcare to every citizen in the country by 2020. And then in 2010, the World Health Organization published its annual report focusing on universal health coverage. And then by the end of the same year, China announced it had expanded health coverage to more than 95% of its population. And then India followed suit, also pledged to provide easily accessible and affordable health care to all Indians by 2022, I believe. I think I mentioned India and China because this is very encouraging, given that the two most populous nations, that is close to 40% of the world's population, right, pledged to implement universal health coverage. So if everything goes well, in 1 decade, we could have most of the world's population covered by some kind of health insurance. That would be I would say, a milestone development. in human history. Then in May 2011, the World Health Assembly in Geneva formally adopted a resolution calling for a worldwide implementation of universal health coverage. In fact, the WHO Director General Margaret Chan described universal health coverage as, quote unquote, the single most powerful concept that public health has to offer. And the Vatican also jumped onto the bandwagon of universal health coverage in May 2012 by declaring universal health coverage a fundamental principle of church thinking and engagement in global health, essential for human equity. And then, of note, in June 2012, the U.S. Supreme Court ruled that the Affordable Care Act is in accord with the Constitution, therefore cannot be struck down on judiciary grounds. And that culminated in December 2012 with the UNGA, United Nations General Assembly, adopted a resolution on universal health coverage unanimously, encouraging all nations to plan or pursue the transition toward universal access to affordable and quality healthcare services. So we saw this unprecedented support of the universal health coverage agenda over the past 4 or 5 years. And that also significantly boosted the chances of having universal health coverage included in the post-2015 UN Millennium Development Framework as a sort of like a unified and central health goal that crosses political and economic lines. In fact, I have this piece from the Japanese Prime Minister Shinzo Abe. He actually published an article focusing on universal health coverage by saying, quote unquote, I first and foremost spare no efforts to incorporate universal health coverage as a crucial element of the post-2015 development agenda. And I will reinforce Japan's assistance to developing countries to work with them to achieve universal health coverage. So I think this is a very encouraging development that the United States finally joined that movement. But because, well, this is a global momentum, right? We have already countries have this experience of implementing universal health coverage. I think it also makes sense to examine the lessons, right? The implications of implementing universal health coverage. There are several lessons we could draw. First, scalability doesn't necessarily mean sustainability. Right? In other words, you could, within a short period of time, expand health coverage to a majority of the population, but that doesn't mean you're going to be able to sustain the program for long. In fact, in many of the high-income countries, we found, including Taiwan, and also countries like Ireland, Greece, Portugal, Italy, and Spain, they have actually become increasingly difficult to sustain the programs. Well, due to, in the case of Ireland, for example, that is because of the financial crisis. But in other cases, we also found that these high-income economies are struggling to cope with this flattening economic growth, the globalization of diseases, population aging, the rise of non-communicable diseases, and increasingly costly medical technology. And secondly, increased coverage is no guarantee of lower out-of-pocket costs or reduced financial hardship. And there's also no guarantee that expanding universal health coverage will lead to reduced inequality. In fact, we found that in some countries, inequalities persist, especially when the benefits accorded by universal health coverage become sort of like an inferior good, only consumed by those who have no other choices. So I think these are some of the lessons I think United States might find useful in implementing its own universal, the affordable health care agenda. Thank you.
Thank you very much. among the panelists, and I'm going to use my role as moderator to pose the first question, and it's a dual question. There is a view that said that the Affordable Health Care Act is a conservative approach. The connotation of Obamacare is that it's not conservative, but you could call it Romney Care as an implemented in Massachusetts, or the Heritage Foundation also put forward a proposal for universal health care on the grounds that there should be no free riders. All consumers should pay. So from that point of view, maybe this is an idea whose time has come, that there's no free riders, because Congress was very careful to distinguish between access to health care insurance and access to health care. The other thing that I find very disturbing is Dean Hansel's discussion about the underfunding of hospitals, and that with the expansion of Medicaid in particular, that hospitals may be put on the, in the position where they have to close, and that would be a very, very bad outcome. It seems to me the simple solution is you simply raise the reimbursement rates under Medicaid and Medicare, but that means we go back to higher taxes. Right? So those are the questions I throw out for the panel. Then we invite you to discuss with each other.
I would just comment on what the public payer Medicare has done to the reimbursement for patient care. Medicare, since its inception, has under-reimbursed healthcare providers. A physician or a nurse practitioner can opt in or opt out. Some opt out and refuse to accept Medicare or Medicaid. Medicaid is even more problematic because the reimbursement is even less. And I don't think this is well known. This came to my attention when I was reviewing some hospital bills for my mother, and I just didn't believe how little the reimbursement was. And the reimbursement to the physician was about a third of what an insurance company would reimburse. And I think what has happened over the years is this under-reimbursement has driven up the cost of the insurance that is offered to us in the commercial market. I know here at Seton Hall, having served on the benefits committee, that our insurance rates go up each year, and it's based upon our utilization. Now, college professors tend to be the majority of the employees here, and they tend to be more senior. This is not a young workforce. So, I mean, we have a very, very expensive policy. So I think it's dynamics that are driving the cost up, and it's not going to get better. It's only going to get worse.
I want to add just a few little comments about the hospitals as well, because the idea that hospitals are making huge profits is not true. And in New Jersey, we do have what's called a watch list, and that looks at the hospital's income statement, and when they get below 3 months worth of funding to cover their bills, then they go on to this watch list. And it's not like there's one or two hospitals that New Jersey is watching. There are several hospitals that are at this borderline. Part of it is the fact that the reimbursement has not been appropriate to the level of care. Part of it is the idea of community benefit that every hospital needs to give back to maintain its not-for-profit status. And we can talk a lot about that. That's a whole nother issue. But if you try to put this in context with what the Affordable Care Act is trying to do, it's trying to provide access to the healthcare providers and the hospitals. Now, in terms of whether it was a conservative or was it forward thinking, I think they took a huge step in saying, let's look at this as a population-based strategy. I'm not sure that they looked at it in that direction when they were talking about reimbursement.
I too have looked at the cost of my mother's health care when she was hospitalized. And what really confuses me is, what is the real cost? A hospital, for example, bills $18 for an aspirin, right? They get reimbursed, let's say, $1 for that aspirin. Is the real cost of that $18, and are they really being under reimbursed by $17? Or is the true cost of that $1.50 and they're only getting unreimbursed by 50 cents? Because I think what's happened over time is that because everyone realized that they're getting under reimbursed, well, let's just jack up the cost that we constantly charge. And eventually, we'll get a little bit more out of it. I don't really know what that cost is. I don't know what that true cost of delivering, and I'm using the aspirin as an example here. What is the cost of that aspirin that the nurse walks into the patient? Well, we've got to, first of all, probably fully cost that out. It's not just the cost of paying Bayer for that aspirin, it's the cost of the labor and the cost of the lights and everything else. And I think that's part of the system. We just don't know what the cost of that delivery is. And I don't really think that we have a good grasp over what our healthcare costs in this country, which is part of it. And what we're trying to do is we're trying to create a system over something that is very amorphic from an economic point of view. And that's what really troubles me. In outside of healthcare, you walk into Macy's. Macy's has a nice Ralph Lauren shirt, and the price of that Ralph Lauren shirt is $100. Okay? But now they've marked it down to $45. What's the real price of that? Is the real price the $100 they think that they're making you believe is $100, or is the real price maybe $50 and they give you a 10% discount? The problem is, I don't know, and I don't think anybody in the healthcare system knows, and certainly no one in the government knows, but I like to know what everyone else thinks.
Well, I agree with Scott that one of the U.S. health system is the healthcare cost, right? And you mentioned that you don't know what the cost is. Well, that is reflected actually in the so-called charge master in the U.S. Actually, you ask any expert, they can't explain what that is. Even though they knew it's originated in the 1970s, but nobody could explain what it is, why the price is set this way. And I think the issue that the Obamacare needs to address. And in the meantime, there's other issues. Certainly, price transparency is important. But in the meantime, I think in order to bring down cost, you got to allow, for example, the Medicare to negotiate with, for example, pharmaceutical firms to bring the prices down. Well, that is still not allowed. And you also, unfortunately, this issue not addressed by Obamacare is the malpractice tort law. Right? Why is that the case? I was attending a meeting this morning at the Council on Foreign Relations. Actually, one of the attendees pointed out that the biggest contribution to Obamacare act is from the trial lawyers. They're affected the decision. Why that issue is not addressed by the Obamacare.
I'd just like to relate another personal experience with the hospital bill. And this is the bill of a 20-year-old healthy college athlete who develops an infection that manages to work its way into the bone. He was hospitalized for a week. The bill was $33,000, and the insurance company, which is Cigna here, because the hospital was in network, reimbursed the hospital $7,000. Now, my read on that is that even the insurance companies that we are paying big money for are under reimbursing. I mean, you look at a place like St. Vincent's Hospital, large New York medical center, who serve primarily its local community, a community that has a significant amount of poverty and probably a lot of government payers. It could no longer continue to stay afloat. We look at the hospitals in Newark and Orange. Orange Memorial is gone. United Hospital is gone. St. James is gone. St. Michael's is holding on by a thread. I don't know where it's all going to go. It's very, very scary. And I think the question is, what is the real cost? I don't think anyone knows. I've never heard a health economist really drill down and address that.
We do have a health economist on our faculty, and we invited her to speak, except that she's at a conference this week. So if we continue this next year, as I expect we might, she'll be available if we have it earlier. So we do have a health economist, but true.
I'm just going to jump in here real quick. The transparency question is one that's been around a long time, and if you can understand your hospital bill that good, you're making quite a headway, I think. Yes, they do. There are ways to figure out exactly what the cost is of that service, but I think what we've encountered over the years is the hospital is mandated to take care of anybody who walks in that emergency room door and provide the customary care to take care of them. Now, if those people walk in with no health care insurance, where is that money coming from if the state is only reimbursing 5 cents on every dollar? And part of the money that you pay for the Kleenex is covering that person that couldn't pay. So why not have health insurance for all, do the risk pools, and move into that direction? I really like your analogy with the Ralph Lauren outfit, because in healthcare, we don't have sales on appendectomies. You know, you can't go to a hospital this week and have, hip implants 20% off. So there is a little bit of a difference, and I'm just joking.
That's all right. I want to jump to what Professor Alexander asked before, whether or not this is a Republican or conservative plan. And certainly Governor Romney instituted a statewide plan in Massachusetts, which a lot of people happen to thought was a good plan. And I think this is part of the problem with the Affordable Care Act. First of all, what we try to do is we tried to do a nationwide insurance plan. Right? You talked about scalability before. Very difficult to scale against 50 states. Let's understand something, the history of our country and the way in which the Constitution is written. I'm a constitutional attorney, and by the way, you talked about the tort lawyers. Yeah, well, my son just got his bar, and he wants to go into litigation. So I'm probably talking against him. But each state is, in essence, their own mini nation. Right? And anything that occurs within the state is regulated by the state's own laws. Right? So for example, the state of New Jersey has its own insurance commission and commissioner. Right? They do a pretty darn good job with health insurance. I'm sorry, with life insurance, with auto insurance, and other insurances. Why not leave it up to all the states? Why not mandate the states for them all to come up with their own insurance plans and leave it within the states? Because again, scalability is important here. The way in which you handle healthcare in Massachusetts, New Jersey, is going to be far different than the way in which you handle healthcare in Texas or Arizona. And so what we try to do is we try to have a global solution which really didn't fit. Let's also understand something from the point of view of, let's assume that healthcare is a business that you want to expand across the entire country. I can tell you this, when McDonald's opened up, it didn't decide to open up 100 restaurants in 50 different states. It starts with one. It learns from its mistakes. It learns how to price. It learns price discovery, right? And I think, unfortunately, what we try to do is we try to say, you know what, let's do it across the entire country. And I think that's part of the problem. Maybe every state needed its own Romney care, so to speak. But it had to decide for themselves without mandates and let them tax, let them price things on their own within their own economies. Let's understand something that a lot of people say, well, the economy is not good in this country. Well, guess what? The economy is very good in certain geographies, and it's very poor in other geographies. I speak to people down in South Carolina. They complain how bad the economy is. But guess what? It's not so bad in the New York metropolitan area, and it's not so good in the D.C. metropolitan area.
All right, thank you. We want to get to some questions, and Professor Riley is our moderator from the floor.
Yeah, good. How, describe how nurse practitioners can impact the healthcare system under Obamacare. And from teen pregnancy to drug abuse to incarceration rates, more equal societies are healthier, statement by Robert Reich, former Secretary of Labor. So are we treating the symptom, the sick uninsured, not the problem, income inequality?
Nurse practitioners are the best. We've educated nurse practitioners here at Seton Hall since the late 70s. There is a lot of opportunity within the Affordable Health Care Act to support the work of nurse practitioners. And nurse practitioners are especially effective at managing chronic illness and helping individuals stabilize their illness. There have been numerous research studies done over the years comparing patient outcomes, comparing physicians, primary care physicians to primary care nurse practitioners. And nurse practitioners have patient care outcomes that are equal to or better than. They're very holistic in their approach, and when working, let's say, with an elderly individual, they would look at the total lifestyle and incorporate nutrition and look at the whole patient. Oftentimes, an elderly individual will be going from doctor to doctor, and nobody's pulling it together for them, and this is something that a nurse practitioner does very well. So the nurse practitioner population is growing. The new emerging standard is for nurse practitioners to hold the degree of Doctor of Nursing Practice, which we are offering now at Seton Hall. And I think we can make a tremendous difference. I think the key to cost saving is keeping the population healthy. And you don't want to end up in the hospital where the cost is high. You don't want to end up with the chronic illness. You want to prevent diabetes through preventing obesity. You want to have good nutrition. You want to have a solid lifestyle, and that's very important. The second question is interesting, and I don't know quite how to answer it. In looking at health outcomes around the world, as Professor Wong was pointing out, I don't know that our problems are any worse than most. I think a lot of the problems that we have, teenage pregnancy, drug addiction, are related to things like poverty, um, challenges that our population has. I've spent some time with students in Denmark, and we have students that can have an exchange with a university there. And it's very, very interesting how the focus is heavily on prevention. And I've never seen people eat so many vegetables in so many different colors. And nobody is obese there because they don't have automobiles. They use public transportation. They walk around. And the population is quite homogeneous. The United States has a very mixed, heterogeneous population. So we have different strata of the society that have different healthcare issues that are probably culturally embedded. So my personal opinion is that the Affordable Health Care Act is probably going to do little that is measurable to change patient care outcomes. I think the key will be more nurse practitioners that will focus on prevention and stabilizing chronic illness.
Is there a national healthcare system animal in your particular would label the best known solution? And does one act protect personal well-being?
Thank you for the questions. So I assume that you're asking whether any best cases of healthcare worldwide. Well, the answer really is no. And, well, some people say that Sweden might be a good example, but even there, they have their own problems, reforming it. Singapore probably provide a more efficient system because they only, I think, healthcare cost as a percentage of GDP is only like 4.1%, but it was able to provide national health insurance to its population. But Singapore, population-wise, it's as large as Brooklyn, I think, in New York, right? So really, that doesn't provide a very useful reference point for the United States, which has a 300 million population.
The answer is no. And the countries that you do mention are not the ones that would necessarily readily provide what Singapore. So the question is, with the current economic climate in the U.S., is it necessarily the right time to implement Obamacare, given the ways in which the law quote-unquote hurts businesses? I would say that the theme also was about how to, is it hurting businesses, or are we recognizing that government has been continuing to subsidize our corporations compared to other countries?
You're going to take that. I'll put up your slide if you want me to. The slide you didn't show.
Sure, if you want to. Sure, thank you. Well, I think I said before in my prepared remarks that there's been a negative impact on the housing market. ADP, which is one of the largest payroll companies, has already noticed that over the course of the last few months leading up to the implementation of Obamacare, that temporary payrolls have increased relative to full-time payrolls. This is just an example of trying to figure out the penalties under Obamacare, and this is a maze. Now, it's one thing if you're a large corporation, let's say you're General Electric, you've got a pretty well-established human resource department, right? They're adept at figuring this kind of stuff out, going out and getting prices on healthcare. Let's say you're a small company. You've got 50 to 100 employees. Usually, what you do for for your employees is you outsource a lot of your human resource and a lot of your insurance needs. Right? Now it just makes it a lot more complicated. Right? And if anybody hasn't run their own business, it's pretty hard. You know, it's pretty hard that you're trying to make a living with, the economy being sluggish and irregular, and its costs go up. You know, how much can you pass on to consumers? Well, it's very hard to pass costs on to consumers these days. Why is that? Well, because first of all, we don't have much inflation. Without inflation, people aren't seeing their incomes steadily rising. It's very hard to push off costs. And I think that what we're going to see is that more and more small businesses will push back against the law. Potentially, you will see small business formation actually decline. What will happen is you'll wind up with just more larger companies. And getting back to what you say, larger companies tend to get subsidized from the government in one way or another, depending upon what it is they do, either through the tax code, which is a mess as it is. I mean, we took a messy tax code, right, and we just made it even more messier. Here you go. And so I think that's the problems that we face. I think that'll continue and will get exacerbated as we continue with this rollout.
Did anybody else want to comment on that?
I have one last question. I think, Scott, by the way, that sounded like a long, it's doomed still.
Yeah, I think it's doomed. I started off by saying, look, I think it was flawed in the way in which it was first put together.
So I think the next question, I think this should be for the whole panel, but I think the question has to do with how can we work within the law of the act to make it more sustainable? Is there a way to make it more have a longer run, and other than some of the dire consequences of all will, and along that same line, is Medicaid expansion, which I think you mentioned in your prepared is that New Jersey opted in, and one of the things that we continue to hear is that in 2017, the New Jersey state budget was impacted by the shift in the cost from the federal government. New Jersey. So is this sustainable? I guess sustainability is the question. Will this hold? And whether or not
Well, you know, I made a prediction. I was on TV and I had, it was taped in December and I was being interviewed and the person who was running the program of the panel said, can you make a prediction when the Obamacare Act will be voted in? And that was in December. And I said, oh, I'm sure that we will have it by March. And as you know, it wasn't passed until March. And I was sitting there going, is this going to pass or not? And they called me and said, we're going to run your interview. They had a date in March. And I was thinking like, I'm going to look like a real fool. So this time I'm going to be much more careful about my predictions in front of a group. But my take on this is that it is huge, it is very complex, it is very vulnerable from lots of different positions, whether those positions are not having health care providers, whether the hospitals continue their downward spiral, whether the small business owners get together and get some kind of impetus going saying, you've got to change it for us. But I will say that I think it's going to be open to a lot of revisions. And I can't believe that we've already had at least, 3 rollbacks, and another year we'll look at it, we'll look at it again. The one thing that we have to remember about Medicare and Medicaid, how they kept evolving over time, is the government will send out an RFP for grants for states, and they'll say to the state, here's this RFP. We will give you a grant and a waiver to let you change how you're running Medicaid or parts of Medicare. And if it works, if that pilot works, then it gets adopted by other states. And I think this is going to be the vehicle to sustainability for this act.
And it has to do with the administrative costs. So, as I understand it, the administrative costs of Medicare are about 5%, whereas administrative costs for private insurers in the United States is 20%. So that's a very big difference. So Medicare is an efficient product.
I'm very worried, and I'm not at all optimistic. And what concerns me is the aging baby boomer population. And as individuals hit age 50, what happens? The body starts to break down. Chronic illnesses occur in about 50% of individuals by that time. And that is the fastest growing population in this country. Another thing I don't think that is well understood is Medicare doesn't come for free either. And the cost of Medicare is going to go up to individuals, and there are various parts to it. And I mean, you could be an individual in your 70s or 80s, and you could be paying out of pocket thousands of dollars a month for the medications that you need to manage your chronic disease. So those numbers are growing, and the population is living longer. So I think it's a very, very bleak future.
Anything?
If you look at the experience of implementing universal health coverage worldwide, it's very clear, right? Sustainability is a huge problem, not just for low-income, mid-income countries. It is a problem, serious problem for high-income countries as well. And it's particularly a challenge for the United States when you have 18% of the GDP actually spent on healthcare. That is, I believe, the highest in the world. Right? Per capita health spending is nearly, I think, $10,000 close to. That's 3 or 4 times many OECD countries. Right? And unfortunately, so far, our country has not doing a very good job. You bring down the cost, negotiating with the pharmaceutical firms, bring down the drug cost. We haven't done a very good job in preventive care, especially considering that 80% of the cost associated with NCDs, the non-communicable diseases.
I'm sorry, but I've got to turn the tables here a little bit. Professor Raleigh, please step up to the platform, to the microphone. Professor Raleigh is a systems expert who has designed and implemented systems in the private sector. And I'd like to ask you, and
Hospital in Philadelphia. I didn't work.
Right. Right. So my question to you is, from an implementation point of view and a sustainability point of view of healthcare.com and everything that is behind it, is this a system that can be fixed, or do we need to scrap it and start from the beginning? Because as you know, I've worked on Wall Street for many years. A lot of times you walked into a situation, we had to take a system and just throw it into the trash heap and start from the beginning. So as an expert, I'd like to know, what is your opinion?
Very generous. I would say that, first of all, the first thing that was the problem was that a number of states did not opt in and chose to go for the federal place. As a systems programmer, I have coded, I've done databases, I've done hospital billing systems. I'm known a lot about how systems work. To do this properly would have required that if that was going to be the load, people knew about it 3 years prior. So just that fact of what the complexity of all those states and what was needed was well beyond what any fool consulting company signed up to do and implement within the time frame that they said they were going to make it happen. I will tell you right now that it was really. Problem 2 is that they went with one implemented. If they had regionalized the implementation, that would have been huge advantage, not only in terms of differentiating the tendencies for some regions to have different priorities in their Medicare program, would also have been reflected in the style and the substance of the configuration of a regional site that the federal government provided. We didn't do that. That's problem number two. And problem number three is that we're not even close to seeing the real problem. I happen to be a big closet supporter of the plan and what we're doing in terms of what's going on, but I will tell you right now that the back end billing insurance payment process will make this discussion look like a momentary pause in a like over tea discussion. It will feed Scott's propensity to say doom and gloom to the insurance industry, but I've spent a lot of time in business, and I will tell you that insurance companies make a lot of money already.
Is this kind of the Y2K problem come true, almost?
So Y2K, because Y2K,
you and I spent a lot of time on Y2K, and we had lots of staff spending a lot of time on Y2K.
so Y2K, for those of, so that you're all included, many of you are way too young, but when the year 2000, the millennium kicked in, there were a lot of people in technology that the computer systems, all of them, would stop working. It would stop. And there was, it's just like everything, government, airports, airplanes would fall out of the sky, right? I mean, satellites would explode. I mean, the world, people would die and patients would die in bed because some little error and the meds would be wrong, all because of Y2K. It was a huge boondoggle. Boondoggle was one word that people used in terms of the amount of money that was spent on preparing all of the systems for Y2K. It was a non-event worldwide, and some countries chose not to do much of anything about Y2K. And that has been compared favorably to this Healthcare Reform Act in that its implementation is maybe a bit strong for the insurance companies, the payers, the payees, the providers, the hospitals, which we all know, any of us who spent any time in healthcare, are not, make brokerage companies look like the state-of-the-art NASA challenging technology firms, because the healthcare industry is woefully behind in the most basic data processing, structures, use of technology, information processing. We're talking that my phone probably has more apps available to it for me, managing me, and my health care than most hospitals provide to their patients. So I think that Y2K is an appropriate answer, but there's a lot more work to be done here than just fixing Obamacare.
Thank you.
All right, thank you. Thank you for coming. Dean Strauser, thank you for hosting, welcoming us. Thanks to the panel for a very stimulating, if somewhat depressing, discussion. And let us thank the panel. And I invite you all for further discussion and a reception out in the foyer.